The presentation today. Thank you to Bristol Myers Squibb, Jazz, Novartis, and Taiho for supporting this webinar program. Please note that this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers opportunities for all participants are included at the end of this presentation. Today's presenter is Dr. Michael Kang. Dr. Kang holds a clinical faculty appointment in medicine in the Division of Hematology Oncology at UVA Cancer Center. He practices at the Emily Currick Clinical Cancer Center in Charlottesville and serves as an inpatient hematologist at UVA Hospital. His clinical areas of interest are myelodysplastic syndromes, myeloproliferative disorders, acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia, and aplastic anemia. He attended medical school at Michigan State University in East Lansing, Michigan, and completed internal medicine residency at the University of Southern California. And in 2014, he completed fellowship in hematology and medical oncology at the Cleveland Clinic, where he served as chief fellow. With that said, it is my pleasure to introduce Dr. Kang.
All right. Good morning, everyone. It is my distinct pleasure to be here today and present to you on myelodysplastic syndromes. As Audrey said, my name is Michael Kang. I am from the University of Virginia, and thank you so much for being here today on a Saturday and to be able to learn and to have a discussion on myelodysplastic syndromes. The topic today is updates on myelodysplastic syndromes. What I wanted to do is start on focusing on the basics first, since there are some changes to that, and then talk about the updates of what we've learned over the last few years. There are a lot of slides. This is meant to go very quickly, and I apologize if things go a little bit faster than here and there. So please enter your questions in the Q&A chat function, and then we'll be able to answer as many questions as possible afterwards. I do not have any disclosures. This is the lay of the land of what we're going to talk about. We're going to talk about epidemiology and staging, treatment of lower risk disease, then higher risk disease, clinical trials, future directions, and then some concluding remarks. So let's start off with epidemiology and staging. Myelodysplastic syndrome is a heterogeneous clonal hematopoietic disorder derived from an abnormal multipotent progenitor cell. It's characterized by hyperproliferative bone marrow, dysplasia of cellular elements, and ineffective hematopoiesis. So I understand that that was a huge mouthful, and that is the most medical definition that we have. In short, MDS, myelodysplastic syndrome, is a cancer. It is a cancer of the bone marrow where cells are just being created incorrectly. Over the next few slides, I'll go through this definition and we'll break that down a little bit more. So what are the shared features? When I said that there was ineffective differentiation and low blood counts, this is what we commonly call in medicine cytopenias. So that is a low white blood cell, red blood cell, and platelet count. There's also clonal expansion of abnormal cells. What does that mean? There's abnormal chromosomes, and that's sometimes found in the karyotype. And there's also abnormal somatic mutations, which some of us in physicians call gene mutations. There is a characteristic of dysplastic hematopoietic cells. So when you look under the microscope, you will see that these cells don't look normal. They may be abnormal shape and sizes, so therefore the function is not as correct. And then there's instability and risk of transformation to acute leukemia, generally acute myeloid leukemia or AML. This afflicts about 15,000 to 45,000 people annually, and the incidence rises with age, with the mean age of 71 years old. So back in 2008, this is looking at SEER data, and it looks at patients who are newly diagnosed, and that the median age is about 71, as I said. It occurs in men slightly more than women, and then the duration of myelodysplastic syndrome is anywhere from 13 to 16 months. Most patients have primary myelodysplastic syndrome, with the most common secondary cause is from previous chemotherapy. Remind you, these are older data from 2005 to 2007. So what causes myelodysplastic syndrome? On the left-hand side, you'll see that the most common cause is what we call de novo, idiopathic or primary. For the lack of better words, it's just kind of bad luck. So about 85% of patients have de novo MDS, and the risk increases with age. 10 to 15% of patients have prior ionizing radiation or certain types of chemotherapy called DNA alkylating agents. And about less than 5% of patients will have had prior topoisomerase 2 inhibitors. That's another specific chemotherapy. As you can see, the majority just occurs from idiopathic by itself, not from secondary chemotherapy or radiation in the past. This slide just shows you at the very bottom what the expected chromosome types are. Most patients with de novo have normal karyotype, meaning without any mutations or without any gene mutations. In the patients from secondary radiation or chemotherapy, these patients may have other other gene mutations that are most commonly seen, and these are listed down here. What are other causes to myelodysplastic syndrome? We already talked about aging as the first one and exposures to chemotherapy and radiation. Sometimes myelodysplastic syndromes come from previous disorders, such as aplastic anemia or paroxysmal nocturia hematuria, or PNH. There are some genetic inborn disorders that patients are born with that can lead to future myelodysplastic syndromes. We don't have time to go through all of them here, but this is just a list of previous disorders that you're born with that may lead to future myelodysplastic syndromes. This is a classic figure from medical school where you have the first stem cell here, and these stem cells, based on different signaling, gets differentiated, meaning gets kind of more and more mature, and it gets matured to a common lympho progenitor cell versus a common myeloid progenitor cell. In myelodysplastic syndrome, this myeloid cell is the one that we care most about. So this common myeloid progenitor cell differentiates to many different things. It goes to the erythrocyte, or what we know as the red blood cell. It can go to a megakaryocyte, or platelets, and then it can differentiate into all these other different cells at the bottom, which are different white blood cells that we know as the neutrophil, the monocytes, eosinophils, and basophils. Now, this is very complicated. So if there are mutations or if there's something that's wrong in this process, unfortunately what happens is then mutations occur and your body may have a harder and harder time to fix those mutations, which may develop into myelodysplastic syndrome. So you have a common cell here, and time is on the x-axis on the top, and transformation is kind of as you go down. Normal, you get your healthy red blood cells, your platelets, and your neutrophils. However, if a mutation occurs, hopefully your body's immune system can catch that and fix the mutation before it really causes havoc. But if it cannot, you may have some abnormal looking cells. And at this time, this is very similar to early myelodysplastic syndrome. If you develop more and more and more of these mutations, then it becomes advanced myelodysplastic syndrome and late stages or higher risk. And we'll talk about those risk categories later. And if you develop even more, you may develop something called secondary acute myeloid leukemia, something that is from the myelodysplastic syndrome. All right. In 2015, Dr. Siemsma from Boston, he looked at kind of the mutational landscape, and he published this article. These are the top 40 mutations that occur. There are a lot more than 40 mutations that can occur, but these are the top ones that occur with myelodysplastic syndromes. It's broken up into different categories. These genes on the top left affect proliferation. Proliferation means cell growth, and then so on and so forth. The ones that I just really want to show you is that the size of the bubble is just how often these occur in that specific category. And the big one that we know is the most one to really watch out for is this one right here under other, which is the TP53 mutation. And there will be future slides on this specific mutation. Myelodysplastic syndromes is a category that fall under what we call myeloid malignancies. There are many common features to other type of disorders, and just a few of them are listed here. So when you go see a physician and your physician says, I think you may have myelodysplastic syndromes, but I need to do some other workup, this is the reason why, is that there's so many cross similarities with, for example, aplastic anemia, or even acute myeloid leukemia or myeloproliferative neoplasms, that we need to be 100% sure. Over the next few slides, I'm going to go over kind of the updated definition of what really makes up that myelodysplastic syndrome definition and why it's so important that we really know. Because treatment, for example, for acute myeloid leukemia may look different in certain settings than myelodysplastic syndromes. So what I always tell my patients is that I want to be very careful and I want to be very specific. I'm trying to really figure out, do you truly have a diagnosis of myelodysplastic syndromes before jumping in? So this part may take a lot of time, and I really encourage patients to have their bone marrow biopsies reviewed by a center that really specializes in myelodysplastic syndromes, and that they have dedicated hematopathologists and hematologists to know what they're looking for. Now, the NCCN, the National Comprehensive Cancer Network, puts out several guidelines, one specifically for myelodysplastic syndrome. You can see is that when a patient develops cytopenias, meaning low blood counts, there are many things that need to occur. I don't have time to review all of them, but there are many things that can occur other than myelodysplastic syndromes. So just because you have low blood counts doesn't mean that you have myelodysplastic syndromes. You have to go through this type of thing and rule these things out before meeting the definition of MDS. So what do you need? At minimum, we recommend a bone marrow aspirate and biopsy. The aspirate is the liquid portion of the bone marrow. The biopsy is the solid portion from the core. We want to correlate this with the complete blood count, specifically with the white blood cell differential. And then we want to look at the karyotype. That's the chromosomal analysis. So that's the minimum stuff that we would need. Additionally, we would look at a FISH panel and flow cytometry on the bone marrow aspirate itself. And now there's specific genetic testing that we look at. And we already talked about the 40 most common mutations on several slides back. In 2006, the WHO, or the World Health Organization, came up with new diagnostic criteria. So at minimum, you need to have a meeting the bullet A and one of the bullets B1 to B3. So at minimum, patients need to have meaningful cytopenias, low blood counts. And we'll go through what the specific definition of those low blood counts are. And one of the following: increased blasted leukemia cells that we don't want to see in the bone marrow. Anything greater than 5% up to 19% is what will meet the definition of MDS. Or extensive dysplasia. Remember, dysplasia is when those cells look funny, and that's greater than 10% in a lineage. And the lineage is basically the red blood cells, the white blood cells, the platelets. Lastly is the karyotype, meaning are there any chromosomal abnormalities that would be very similar, that's common in the era of myelodysplastic syndromes? So you may have criteria A, but not have criteria B, 1, 2, or 3. If that's the case, you may have a diagnosis of Icus, which is idiopathic cytopenias of undetermined significance. I know that's a huge mouthful, and we're going to go through that as well. So what I said was you need to have cytopenias, specifically a hemoglobin of less than 11, an absolute neutrophil count of less than 1,500, or platelets less than 100. So that, which is this top left box, added to this top right box, is combining your cytopenias in the decisive criteria. If you have those two, likely you have myelodysplastic syndromes. You do need to rule out other causes, and the other causes are listed here, meaning nutritional deficiencies, infections, if you drink a lot of alcohol, medications, autoimmune disorders, and other hematologic disorders that were discussed. So not only do they meet the top two boxes, you need to make sure that you do not have other reasons to have low blood counts. And that is very important because many things can mimic myelodysplastic syndromes. And of course, those things may be easier to treat and have a very different prognosis. Now, remember what I said was that you may have something called Icus. That's idiopathic cytopenias of undetermined significance. This is something pretty new that was really embraced by hematologists over the last half decade. So Icus, idiopathic cytopenias of undetermined significance, you have the low blood counts, but you do not meet the diagnosis of myelodysplastic syndromes. So there are kind of, that's one of them, Icus, but you could also have what we call CCUS, which is clonocytopenias of undetermined significance, meaning that you have these low blood counts, you don't have myelodysplastic syndromes, but you may have a clonal mutation. Now, this mutation is a gene, not the chromosomes, that would give you the diagnosis of myelodysplastic syndrome. So why am I focusing on so much of this? Because this stuff that I'm talking about here, ICUS and CCUS, can predispose you to having myelodysplastic syndromes in the future. But more importantly, there is some risk to mortality, meaning death. So this slide here shows is that if you have clones that are being developed and you don't have myelodysplastic syndromes, if you are over the age of 70, there is an increase in all-cause mortality. All-cause meaning any reason to death. And so this is the reason why, if we identify these things earlier, I do encourage you to talk to your hematologist about this. Not just only all-cause mortality, the specific things that we're really concerned about is cardiovascular mortality, so meaning things that affect the heart. So this article that was published back in 2017 showed that these clonal hematopoiesis disorders led to an increased risk of myocardial infarction, meaning a heart attack. So there's also these specific disorders can lead to your heart having increased active macrophages and signaling to actually make atherosclerosis worse. So this is really important, not only affecting bone marrow, but also your heart and your heart health. And so this is the reason why is that you may not meet the definition of myelodysplastic syndrome, but having that bone marrow biopsy when you have low blood counts that you can't figure out a different reason for is important. There are many milestones in MDS, and these are just a few of them. The first scoring systems and grading from the FAB, the French American British system, was developed back in 1982. And you can see that the WHO has had revisions to myelodysplastic syndromes all as close as 2016. We probably expect another revision to this WHO every 8 years or so. So we're probably due for one in the next 1 or 2 years. And I'll tell you why that's important over the next few slides as well. The NCCN has listed very nicely this, the biggest categories of the WHO's classifications of myelodysplastic syndromes. So it's breaking up into with single lineage dysplasia, meaning just one or two low blood counts, like red blood cells, white blood cells, and platelets. You can have myelodysplastic syndromes with ring sideroblasts, myelodysplastic syndrome with multilineage dysplasia, or with excess blasts, or things being unclassifiable, or with a isolated deletion 5 mutation. So these are the big things that we look for, and we break them up because it does help with some sort of treatments. But what's actually more important is your risk score. So the classic question I get when I see patients is, what stage am I? Well, myelodysplastic syndrome is not scored or staged like lung cancer, for example. We do not have stages 1, 2, 3, 4, where 1 being the least severe, 4 being the most severe. What we do instead is we do a risk score. So the first risk score was developed very early, and this was called the IPSS risk scoring system. And you can see that it uses someone's amount of blasts, those bad leukemia cells in the bone marrow, with the DNA chromosome mutations, plus the low blood counts. You get a score, you get a point for each, and each one of these points adds up to a specific score. And that score will make you have a group of low, intermediate 1, intermediate 2, or high risk. And that helps with median overall survival in years. And you can see that this is on a graph here. If you have low risk, you live longer than patients who do not have low risk myelodysplastic syndromes. Now I'm comparing it here because this is compared with non-small cell lung cancer. You could see for stages 1, 2, 3, 4, it's very similar. So I put this here because line for line, you actually are very close to having lung cancer survival stage by stage. And I just put this down here for patients who have myelodysplastic syndromes if they don't know why I, as a physician, can be concerned why we need to do treatments and why we need to follow closely, because this rivals mild lung cancer. Now, this lung cancer curve was back in 2009, and there are many newer therapies. So the lung cancer curves actually have improved quite a bit. And so that may mean that MDS may be harder to treat than lung cancer. And that's why we want to be very careful in talking about these specific survival curves. Now, this is an old survival curve. And what we do now is using the IPSS-R, which is revised. This is something that was published back in 2012. So still about a decade ago. What they do is they actually split up chromosomes a lot more. And you can see that the chromosomes go from very good to very poor. And they actually look at hemoglobin, neutrophil count, and platelets very specifically and split apart. And they also still look at the myeloid blasts in the bone marrow. Now, you can see that the blasts are very split up and finely, because there's ones that are less than 2, 2 to 5, 5 to 10, and greater than 10. You can see that this is very hard, and it takes a very, very trained hematopathologist to try to really figure out what bone marrow blasts ultimately you have in the amount. So this is why I do recommend that these bone marrows be reviewed by someone who's trained to look at them and be interpreted correctly. So the MDS Foundation has a very nice calculator. It's called the IPSS-R calculator. You can click on this and you can actually see what your risk score may be. And your risk score goes to from a group now to very low to very high. And this will help you understand what is your risk in developing acute myeloid leukemia and then surviving with myelodysplastic syndromes. Remember, these curves may look scary, but please interpret this with a hematologist, because these there are limitations to this scoring system. What are the limitations? The limitations include, before I get to the limitations, the big limitation is it does not include any of these genes. Remember, we had those 40 genes that were listed earlier, but this scoring system was developed back in 2012, and these genes were not even developed, and we didn't even know about them at the time. Well, we knew about them, but we didn't know what they meant. And so, unfortunately, because it doesn't include these genes, you may have a good gene or you may have a bad gene that may develop and change how we interpret your score. And so what I tell patients is that this scoring system is only valid for adults. It's valid for de novo, meaning newly treated, a newly diagnosed disease, and patients who are treated with supportive care at the time and the time of diagnosis. If you've been treated for with immunosuppressive therapy or hypomethylating agents already, this scoring is not valid. It does not include gene mutations, and there are different scoring systems that are looking at this specifically. So I talk about it because it's important to know that these risk scores are very important for us, and it is the only thing that really helps us put patients in different categories and when we start talking about specific treatments. However, please interpret this with a hematologist, because your risk score may not be what you really think it is, and it has to be augmented based on your whole history that is there. So hopefully that made sense. This is just a brief diagram that looks at when patients are asymptomatic to becoming symptomatic. So your bone marrow function decreases while your transfusion amount does increase. And we'll be then talking about specifically these different treatments that are listed here. So moving on, we're going to start off with lower risk treatment. So this is a diagram that's been published by Dr. Ccus and Patel from Cleveland Clinic, and now he's at University of Miami. And we're going to go through this. So when patients are diagnosed with lower risk myelodysplastic syndromes per the IPSS-R, we may just want to observe. So patients without transfusion needs, with a good quality of life, a very real treatment is just observation. So many patients tell me, that means you're not treating. Well, I want to say, hold on, because treatment may be just observation. Because if we don't need to give treatment and save you from medications, we can save patients from unneeded adverse effects. So this is a very valid treatment option. There are treatments geared for anemia, hemoglobin, treatments geared for thrombocytopenia, meaning low platelets, or if you have multiple problems like low hemoglobin, platelets, and even low white blood cell count. So let's focus on these low counts first. If you have low hemoglobin, and that's the medical term is anemia, you can get red blood cell transfusions. The big effect is that you may have immune mechanisms against future red blood cell transfusions. You may have iron overload or volume overload. And those are things that we'll talk about later as well, specifically iron overload. If there is low white blood cells, we do not do white blood cell transfusions here in the United States. It is very dangerous, and there are, it's not clinically proven to have improvement from that perspective. And low platelets or thrombocytopenia can be ameliorated by platelet transfusions. And side effects of platelet transfusions include transfusion reactions, and you can have HLA sensitization, meaning that you get more and more antibodies against future platelets, meaning not being able to get the benefit of future transfusions. There are growth factors that are available in the United States. There are specific red blood cell, white blood cell, and platelet growth factors. I do want to say is that for red blood cell growth factors, we use them all the time. However, there are safety concerns in solid tumors, but not in myelodysplastic syndromes at this time, and there is FDA indication for that. For white blood cell growth factors, there's no survival benefit that is seen at this time, but it may decrease infections. For platelet growth factors, these are still relatively new. The risks are still being defined, and there are reports that there may be increase in myeloblasts in select patients. This is not approved yet in the setting for myelodysplastic syndromes, only in ITP or immune thrombocytopenia and aplastic anemia. So let's go through some of the trials. So this is looking at patients that received ESAs or erythrostimulating agents. So these are red blood cell growth factors. So this looked at patients that received them, and this is a study from 2007. So out of about 1,500, close to 1,600 patients, patients who responded with the growth factors is about 40%. So that's amazing, right? 40% of patients had a response in growth factors. And so this is the reason why choosing red blood cell growth factors initially for those who have anemia can be very helpful. Now, how do you know if you're going to respond to a red blood cell growth factor? There is a scoring system that's been developed and published back in 2003. And what it specifically looks for is serum erythropoietin. That's a hormone level that tells your body to make more red blood cells. And it also looks at the specific amount of transfusions that a patient receives per month. So basically, the lower the hormone level that you have in your body, and if you need less blood that's transfused per month, that gives you a higher score, which will allow you to have a better response than those who need more red blood cell transfusions per month and who have a higher erythropoietin hormone level. This algorithm looks specifically at supportive care, allowing patients to have crossed over. And so what this is basically looking at is that there's no specific overall survival benefit with just EPO level by itself. But what this does help, and this doesn't show, is that we do have patients who actually have great improvement in quality of life. And that's what I really want to focus on, is that quality of life has improved significantly in patients with the red blood cell growth factors. Back in 2020, this was a landmark article published by Dr. Fanau in the New England Journal of Medicine. Specifically, it looked at luspatercept. Luspatercept is a new growth factor. It does not work by increasing the erythropoietin hormone. What it does, it looks at improving red blood cell production in a different mechanism. So even though patients have been on growth factors prior, patients could actually do still well on luspatercept because it's a different mechanism. So there was about 153 patients who received luspatercept, while about 3/4 of them received, half of them received placebo. And you can see that patients who received luspatercept really had an advantage of decreasing needs amounts of red blood cell transfusions, even by the 8-week mark. But commonly what we want to maintain is specifically is we wait at least 12, if not 16 weeks. And you can see that there has been improvement in a overall majority of our patients from that perspective. So this is statistically significant. If you look at duration of transfusion independence, meaning that if you do not need any red blood cells and you become transfusion independent, how long do you stay not needing red blood cells? Those who received luspatercept, there was a long time that patients do not. And you could see that patients on average had a duration of at least 30.6 months versus 13 months of those who received placebo. This next series of trials looked at a specific medication called lenalidomide, or Revlimid. Revlimid was looked at in patients with the specific mutation of deletion 5q and patients without deletion 5q. So we're going to talk about patients with deletion 5q first. So this trial, published by Dr. Fanau again in 2011, looked at patients with deletion 5q mutation. And what they looked at was giving different doses of lenalidomide. And if patients received even smaller doses of lenalidomide, 5 milligrams, there was on average a 51.1% transfusion independence. However, if patients received 10 milligrams of lenalidomide, some patients were able to even get up to 61% of patients got transfusion independence. So that is amazing, right? That 60% of patients can not need blood after just a single pill daily. Those patients who were able to achieve transfusion independence did that on average 2.2 years. So these are patients that were having the deletion 5q mutations. Those who do not have deletion 5q mutation still had a response. Dr. Santini and colleagues published this in 2016, that about 27% of patients without deletion 5q can still have a response to lenalidomide. The response was not as long as the 2.2 years. It was about 32.9 weeks. So still not insignificant. So this is something that we do really just want to point out, is that even patients with isolated anemia without that deletion 5q mutations, hematologists such as myself, who specializes in myelodysplastic syndromes, do also consider lenalidomide. Lenalidomide does cause side effects, specifically low platelets and neutrophils. So what this does show is that patients that do not have deletion 5q actually are less affected, but those who do have deletion 5q did see a little bit more drop in platelets and low neutrophil count. A rash and diarrhea and fatigue were other side effects that were seen. So we're going to be transitioning now from low red blood cells to now low platelets or thrombocytopenia. So this study was published back in 2014. And what this looked at was a TPO agonist or a platelet growth factor, specifically romiplastim. And this was known as Nplate in the United States. So patients got enrolled, and then they were enrolled and randomized into getting romiplastim or placebo. There was an interim biopsy, and then they did allow some crossovers here and there. So what happened with patients who received romiplastim? So how the study was broken up was that patients were broken up to having baseline platelets of less than 20,000 and baseline platelets greater than 20,000. So if patients started with baseline platelets less than 20,000, their platelet transfusion requirements decreased. So you could see that there was a lot less patients that needed platelets if they received the romiplastim, and that was significant. What was not significant was this CSBE, which is clinical significant bleeding events. So although it didn't decrease bleeding events, it did decrease the overall amount of platelets that a patient needed if they started off with platelets less than 20. If patients started off with a baseline of greater than 20, there was a decrease in clinical bleeding events, and that was significant, but there wasn't a too much decrease in overall platelet transfusions. So bottom line is it doesn't matter if you started off with platelets greater or less than 20, there was a significant in some sort of whether it's clinical bleeding events or platelet transfusion events. Now, there is this warning from the FDA was that there is this concern of these agonists, these TPO agonists like romiplastim, that has led to an increased transformation to acute myeloid leukemia. And so what they found was that those who were enrolled on the romiplastim arm did not die more than placebo, but these patients had an increased chance of getting acute myeloid leukemia. Now, why was that? So when patients were allowed on this trial, they allowed all patients with myelodysplastic syndromes, and including very high risk. And those high risk myelodysplastic syndrome patients actually had myeloid blasts that were in their bone marrow. And so it is very important to know is that these myeloid blasts have receptors that this romiplastim could attack and actually produce into acute leukemia cells. So it is very important to know that in the United States, we definitely want to be wary and not actually use this romiplastim or the sister medication, L-thrombopeg, in patients with higher risk myelodysplastic syndromes. So because of this warning, the FDA did not actually approve romiplastim or L-thrombopeg in a setting for myelodysplastic syndromes because of this very reason. But hematologists like myself, if we know that a patient comes in with very low or intermediate risk myelodysplastic syndromes without any increase in blasts, there are certain settings where we would consider prescribing these medications. There was no improvement in overall survival, and so that is the reason why also the FDA did not allow the indication for myelodysplastic syndromes. Just like with blood, there are platelet criteria that may allow physicians to know if there is a increased or decreased risk of someone to respond to these medications. So again, Dr. Ccus back in 2014 looked at a cohort of patients. He looked at baseline TPO, which is the hormone that produces platelets in your body, and how many prior transfusions a patient has needed. So basically, if the lower your hormone level, and then the higher, the least amount of platelets you've needed, less than 6, you would actually respond, about 50% to these platelet growth factors. However, if you have needed more platelet transfusions or you had a higher baseline hormone level, your response rate would be a lot less, to about 17%. This slide just summarizes really briefly on what is available in the United States for red blood cell growth factors, white blood cell growth factors, and that's listed on top. So platelet growth factors are listed on top, sorry. So the red blood cells are in red, the platelet growth factors are in purple. I apologize for that confusion. Now, the bottom green box here talks about myeloid growth factors or white blood cell growth factors. These have never been shown to improve in survival in the United States for myelodysplastic syndromes or to worsen prognosis progression to acute myeloid leukemia. Growth factors may augment, meaning may make the red blood cell growth factors improve better, specifically in the ring sideroblast subtype. They may reduce infections and hospitalizations in the setting of very low white blood cells in those who have recurrent infections. And there is a theoretical risk of making your white blood cells very, very high or to actually have spleen rupture. So those are things that you may want to talk to a physician about when I talk to patients about white blood cell growth factors in myelodysplastic syndromes. This study looked and published in 2011 and 2014, looked specifically for immunosuppressive therapy. Specifically, it's ATG plus CSA. ATG is antithymocyte globulin, or ATG, and this CSA is cyclosporin. So how I try to describe this to patients is it's immunosuppression. It's trying to restart your bone marrow and trick your bone marrow to actually create more normal cells. This is a intense therapy where patients are admitted to the hospital for about a week, and you're on immunosuppressive therapy for about 6 months afterwards. And you can see here that there are about 31 patients, sorry, I apologize, not 31, 31% patients who had a relative response. The median duration of response is a little bit over a year at 16 months. So this is still something that's really unique. That's not intensive chemotherapy, such as for those who are needing, acute myeloid leukemia type of therapy. It's still immunosuppressive therapy to trick a bone marrow to get into some sort of remission response. And so this is what's really neat and really nice. And this was before the era of Altromopag or Promacta that was approved. So these numbers are actually slightly higher now in the era that Promacta has been approved. So what is the best variable, the predictor for a response? That's actually age. Responses can actually be very durable and may actually help patients with red blood cell transfusion independence on even an overall survival standpoint. What specific karyotype or chromosomal abnormalities help? Specifically, those with deletion 5q actually do not do as well with this, but those with trisomy 8, meaning an extra 8th chromosome in that chromosomal mutation list, actually do better in do better with this treatment of immunosuppressive therapy. This next trial looked at adding lenalidomide to a red blood cell growth factor after a patient has failed a red blood cell growth factor. And so this was actually really unique thinking because, traditionally, if a patient has not done well on a red blood cell growth factor or hasn't responded after a while, we would think, oh, the red blood cell growth factor is not helpful. So what this did was they looked at patients randomized to getting just lenalidomide or Revlimid by itself versus Revlimid plus the red blood cell growth factors. And what they did see here was that there was improvement. So those who received the lenalidomide plus the red blood cell growth factor had an improvement in their red blood cell numbers by 26% of patients actually had that improvement versus only 11%. So this is actually a really interesting data to see. And this was statistically significant. Patients who actually crossed over are listed here. And so that means if they're on one cohort, they can be moved over to a different cohort. So you can see that patients who actually develop response are able to get a response with a combination of the lenalidomide plus the red blood cell growth factor. There was actually no increased thromboembolic events. Thromboembolic just means clots. There was no increase of, arterial, meaning clots in the artery, or venous, clots in the vein. If you received, when patients received the lenalidomide. Lenalidomide does have a risk of blood clots, especially for increased doses, specifically in doses for patients with multiple myeloma. The doses that we use here in myelodysplastic syndrome are quite small, and we do not see the actual risks for blood clots as much as those in myelodysplastic syndrome. There are thoughts of using hypomethylating agents for lower risk myelodysplastic syndromes. And the two that most commonly used are decitabine or Dacogen and azacitidine or Vidaza. Those are the two that's most well known. And so what this looked at are with patients with low, intermediate, and IPSS score are IPSS scoring system. And so what they did was they allowed patients to receive smaller doses of decitabine 3 days and smaller doses of azacitidine also 3 days every 4 weeks. And they were looking to see if there was any improvement in blood counts and also transfusions. What they did see here was that there was an overall relative response. About 59% of patients did have improvement. And then the best time to median response was about 2 months. The average cycles that were received was about 9 months. So this was actually really important because this was an algorithm that really showed that potentially lower doses of Vidaza and decitabine could be used earlier on. What is hard was that longer term data is needed for these type of patients because if you use these two drugs earlier on, using them on later and how that can be helpful and if you'll have a response after is just still question about the patients that were on here. So I think longer term data is needed when we're talking about patients that used Vidaza and decitabine in a lower risk. What are the side effects in these patients? Patients who received the decitabine and azacitidine in the lower risk most often had a bit of nausea and fatigue, and those are the two major side effects. Constipation occurred a little bit more in the azacitidine arm. Now, when we talk about transfusions, those who need less transfusions do survive and do better. And this was a study that was published back in 2005. There has been a lot of controversy on ferritin, specifically dealing with iron overload in those patients who receive a lot of blood products. In a study that was published back in 2008, it showed that patients that have a lower iron level, ferritin, did better in terms of survival and time without acute leukemia. Mind you, this was a retrospective study, meaning that this was looking back at patients, not looking forward where we need more specific studies to be done. This study was the first landmark study that was supposed to look at prospective randomizing patients getting an iron chelation factor and not getting iron chelation factor to see if there was any improvement in actually trying to lower the iron amount in a patient. Now, this randomized design was designed as a phase 3 trial that was supposed to enroll 630 patients. But because there was low enrollment, the target size had to be changed twice and it had to be changed to a phase 2 study with an enrollment of 210 patients total. So therefore, the trial was not designed at the end of all these changes to make statistical comparisons. And that is a huge, I think, blow to this trial is that many people who quote this trial quote it incorrectly because it was not made to have statistical comparisons. So when the data was published, there was just this curve here, and it just kind of shows that those who received the iron chelation did appear to do better. Now remember, this was event-free survival. It's not overall survival. And what this only looked better because of multiple removal of patients, because they could not remove multiple changes to that trial. And so physicians looking at this have different interpretations of how to use this study. And so hematologists may or may not choose to use iron chelation when we're talking about iron overload and myelodysplastic syndromes. What I often do in clinical practice is actually use what has been published by the NCCN and the MDS Foundation, is that if patients are requiring multiple transfusions a month and are expected to, over a year, and they have a very high serum ferritin level and have very low risk, expected to be considered for stem cell transplant and to be have a survival of greater than 1 year, this is something to actually consider to have the discussion about iron chelation to remove the iron in a patient's body. Remember, iron damage does not occur over months or over several years. It does occur over decades. So if someone is in their 90s, giving iron chelation is probably not worth all the cost and also the side effects. Iron chelation can be extremely expensive and can have significant side effects that actually does decrease a patient's quality of life because of the side effects from iron chelation. We're going to quickly now jump over to higher risk disease, and I'm going to try to finish up a little bit faster now. I'll pick up the pace so that we can have time for questions. Specifically, what's important to figure out is if a patient is eligible for HCT or hematopoietic cellular therapy, that means stem cell transplant or bone marrow transplant. If a patient does not want to move forward and does not have a good candidate, we could think about hypomethylene agents. Two that are commonly used in the United States are azacitidine or Vidasa. This study by Dr. Fennell, published in 2009, got Vidasa or azacitidine approved. And this is the curve that's commonly shown, is that those who received azacitidine had a relative response better than those who did not receive it by over 35%. In patients who did receive the Vidasa actually lived on average longer, 24.4 months compared to 15 months. I do just want to put a pause and just say that this is very hard to replicate, meaning that this is great published data, but in real world experience, the 24.4 months is not as easily attained. What I quote patients more commonly is closer to the 15 to 20 months. For hematologic improvement, whether you're looking at red blood cells, platelets, or neutrophils, there was an improvement in those who received azacitidine. Less improvement in the neutrophil count, but definitely more in the red blood cell and platelet transfusion and response. This Cytobeam also has its specific trial. Interestingly enough, based on the patients that were chosen and based on how the trial was designed, it did not show overall survival improvement compared to best supportive care. However, and I'm going to skip this slide and I'll just talk about it very quickly, is that when when the drug company specifically sparsed patients out to just higher risk patients on those who received decitabine, there was an improvement with time to death or and specifically to acute myeloid leukemia. So this is where it's really tricky. Initially, the FDA did not approve decitabine for myelodysplastic syndromes because it did not meet its overall endpoint. But when you sparse out and look at specific subset of patients, this higher risk patients, this is why physicians in the United States do still use decitabine. It is a common practice that azacitidine is used a little bit more frequently than decitabine because of these trials and what was shown here. Oral CesaroZidine and decitabine is a combination. Most commonly is known as oral decitabine, and it is been recently approved back in 2020, and you could see that there has been a complete remission response of about 21%. So this is actually really exciting that there are drugs that are now oral that can be used in replace of IV decitabine. Now, this has not been shown against IV azacitidine, and so we do not know what the decision says. So, in my mind, there's still work to be done to see the true response and how great oral decitabine can really be used in the setting of myelodysplastic syndromes. And this is a summary of what we just talked about. Now, when do we use stem cell transplant? This is a study published in 2013 and looked at patients with lower risk myelodysplastic syndromes. And these were patients that went to stem cell transplant and not stem cell transplant. Those who went to stem cell transplant are in blue. Those who did not go to stem cell transplant are in this kind of yellow gold color. And you could see that patients in lower risk actually do better without going to transplant from a survival standpoint. And so in practice, I do not refer patients to stem cell transplant in the lower risk intermediate 1 setting. However, in higher risk settings, going to stem cell transplant is definitely improvement in survival. Again, you can see that the blue line passes this gold line at about the 1 year mark. You could see that the reason why the blue line does a little worse first is because there are concerns for transplant side effects, specifically graft versus host disease and other transplant-related mortality events. And after the 1 year mark, about 40 to 50 months, the transplant arm does do better. Well, what are my thoughts on stem cell transplant? It is the only curative therapy at this time. All other therapies just kind of augment and try to create some sort of remission. About right now, 10% or less patients actually go to stem cell transplant, usually just because of the age. Patients with myelodysplastic syndromes are often diagnosed in their 70s, and transplant program age cutoff for transplant is about ages 72 to 74. It is important to actually decrease blasts before going to a stem cell transplant. So the goal is commonly less than 10%. The question of optimal timing in the use of decitabine or azacitidine around the stem cell transplant time is still up in the air where clinical trials are being developed at this time. Now to jump to clinical trials or the future directions. What's really, unfortunately, scary is if a patient does not improve after does not improve after hypomethylating agents, decitabine or azacitidine, the median survival is about 5.6 months. And that's been shown back in 2011. So this is why I don't want to use decitabine and azacitidine early on. But when something doesn't occur and when patients start to not respond anymore to the decitabine and azacitidine, what do we do? And so what we want to talk about are different possible drug combinations. We've had 2 really great studies listed up here, the pevonedistat study and the rigosertib study here at UVA. Unfortunately, these trials failed to meet its endpoint, meaning that patients on these trials, the drug companies stopped the clinical trial early because pevonedistat and rigosertib has not improved its endpoint, did not show that there was any improvement. Sabatolimab is a anti-TIM3 inhibitor. There was some very good evidence back in 2021 to show that there was improvement in overall relative response, and that patients were able to get into remission for about 21.5 months. And so UVA had the study open. It is now closed to accrual, and we're waiting for final results on this. There was also a clinical trial targeting specifically that bad mutation that I chatted about earlier, this TP53 mutation. And so this current trial is still we're still waiting for final results, and I think there will be more to hear over this next year about APR246 and how well this actually works against this TP53 mutations. Immunotherapy is a very hot topic in outside of myelodysplastic syndromes, and specifically in MDS as well now. UVA had this ETCTN trial, this ipilimumab combined with decitabine and open, and is now closed, and we're waiting for final results. Hearing the work group is that there will likely be a trial again with ipilimumab and decitabine combined with venetoclax open for the future. Venetoclax is a very popular drug in acute myeloid leukemia, but we do not know its great response in MDS can be really applied at this time. And so this slide just shows that there are many retrospective, meaning studies that looked at that are not placebo, not with placebo arms, and looking forward to show that to see if venetoclax really has its response in myelodysplastic syndromes. So this is something that is really going to be I think a agent for the future in MDS that needs a lot of research. Specifically, this arrow of when a patient does not respond no longer to Vidasa and decitabine, what can we do? I really believe that adding venetoclax is something that is going to be studied now, and we are waiting to see what type of responses do occur in that setting. Here at UVA, we do have a study that looks at combining lepremumab with venetoclax. It is a different monoclonal antibody that attacks the CD47 cells. So this is what's really exciting, is that if a patient no longer is responding to Vidasa or to decitabine, there is a thought of adding azacitidine and venetoclax to this lepremumab to see if there is actually additional ways to attack these bad myelodysplastic syndrome cells. Biocyte, a company, also has had a BST236 molecule. UVA participated in the Biocyte 002 trial, and it actually has showed that those who actually did not receive Vidasa or those who received Vidasa or received decitabine but progressed actually did quite well when receiving this Biocyte agent. This Biocyte agent is cytarabine bound to asparagine. So typically cytarabine is very limited in patients who are older because of higher toxicities. But because of this bounding to asparagine, we've actually seen in this 002 study that patients could receive this drug when they couldn't have in the past. So currently UVA actually has this Biocyte 004 study. So in patients who actually have not done well, who've done well or not done well with azacitidine and decitabine in AML, acute myeloid leukemia, or myelodysplastic syndromes, they can use this Biocyte agent. And UVA was one of the highest enrolling sites for this Biocyte clinical trial, and we've actually shown that patients have done well with this. So what are the conclusions? MDS is the most common myeloid malignancy. Prognosis is affected by low blood counts, chromosome, and abnormalities, genetic gene mutations, and specific blast population amount. Lower risk myelodysplastic syndrome affects on what affects the patient most, specifically the low blood counts. Therapies for higher risk disease should be started as fast as possible. This can prolong overall survival if done as quickly as possible. But of course, goals of therapy, quality of life should always be looked at. And the next frontier is this relapse refractory setting, both in the lower risk and higher risk settings. I want to thank all of you for your attention today. Of course, I want to thank the University of Virginia Leukemia, Myelodysplastic Syndrome, and MPN program. Thank you again to the Myelodysplastic MDS Foundation for inviting me to present today, and all of you listening, and to all of our patients and family for making this possible. Thank you so very much.
Thank you, Dr. Kang, for your wonderful presentation. And thank you all for joining us today. For those who haven't sent in your questions, you can start submitting your questions in the chat box found on the bottom menu bar. And for those who want to revisit this recorded webinar, a viewing link will be sent to all registrants and will be available on the MDS Foundation website for on-demand viewing within 10 business days. All right, let's proceed to the live Q&A. Please bring your questions. Our first question comes from Diane, diagnosed last September with low-risk MDS. Her blood counts are going down slowly, and she's in the watch and wait or wait and see stage. She wants to know, why not treat now or early? Why wait until it gets worse?
So thank you so much for all your questions. So it's very hard. I'm going to give a more generic answer because I don't know all the full settings in terms of this person's particular age and all the different things that have occurred. So in regards to the wait and watch, this observation stage, this is a very real therapy option. Now, medications, all medications can cause side effects. And so when we're dealing with side effects, we want to be very careful because, you know, some side effects can actually make quality of life worse. And if we start using your medications early, you actually may start using what could have been saved for later. So in my practice, I'm very, very careful because, you know, if I know a patient's quality of life is fantastic and they don't have any problems right now and they're actually going out golfing or they're running marathons, why start something that may make quality of life worse? That's number one. Number two is that there's only certain medications that are allowed in, not allowed, but there are only certain medications that I can use in MDS. And if I start using all of them up so early, I don't have anything saved for later. So that is something that is going to be concerning. Now, this question is, why wait until it gets worse? So there are certain settings where you may want to consider treatment earlier, specifically if a patient's near the age cutoff or close to needing or considering stem cell transplant. So if the big question is, I need to head to stem cell transplant quickly or soon, and I'm not able to get there quickly, do I start treatment at that time? So I think that is kind of where starting it earlier may make sense.
Thank you, Dr. King. The next question is from Randy. What are the side effects of luspatercept, and do they lessen over time? And is luspatercept drug contraindicated for a former stroke patient of 4 years ago? And lastly, can this drug increase hemoglobin above 9 or higher, even to a normal range level?
Again, thank you for your question. Luspatercept is an injection. So the most common side effects I see patients having is just site injection and annoyance. It comes in a vial and it's a lot of fluid. So if you increase your dose, depending on your body size, there may be a lot of fluid that needs to be injected. So that becomes sometimes annoying because you can have site injection pain, you can have infection to that site. Other side effects do include the common fatigue. What I see a lot, and that is not as put in the product label as much out of more personal experience, is gastrointestinal side effects, specifically nausea, vomiting, and diarrhea. That can be easily fixed by good antiemetics or anti-nausea medications on top. I actually have seen quite a few patients with dizziness or even vertigo-like symptoms, and often a scopolamine patch, a patch behind the ear, does help with those kind of dizziness side effects. Those are the ones I see most often. Usually, if you don't start off with side effects, I don't see any unless when we start increasing the doses. I have not seen side effects decrease too much over time, unfortunately. If you develop side effects right in the very beginning, those are ones that I just really start treating with, specifically with those agents for supportive care. As being a former stroke patient 4 years ago, I think it really is a good conversation with your neurologist and hematologist because it really depends on what type of stroke it was and where the stroke was from. Just generically, even if you had a blood clot in certain places, that does not preclude you from having this medication. Luspatercept and red blood cell growth factors can increase the risk of clots. They usually increase the risk of clots in this setting when a patient's hemoglobin is above 11. So if a patient's hemoglobin is above 11, we actually do not give red blood cell growth factors, including luspatercept. So hopefully that answers your next question was, can this hemoglobin be increased above 9? Absolutely, it can increase hemoglobins above 9. We actually don't wait until patients get into the normal range because we don't want to keep on injecting patients to get there above 11, because if they do, we have the increased risk of blood clots. So I have seen hemoglobins rise very high, and if it does, we just stop the injections and we wait and watch until the hemoglobin dips below, a certain threshold, then we'll restart again. But this hemoglobin value could definitely be increased above 9, and it works very well at decreasing overall transfusion needs.
Thank you, Dr. King. Great answer. The next question comes from a patient with secondary MDS due to a prior cancer treatment with chemotherapy. They were diagnosed with MDS unclassified. Their blast counts are less than 2% with a mosaic karyotype with 6/20 metaphases, and they have DEL7 and DEL20Q. Although they were diagnosed with an IPSS-R score of very low, they also happen to have the TP53 mutation with 5.5% VAF. Cytopenias to date have been quite mild, and their hematologist has them on watch and wait with blood work follow-up every 3 months. And they would like you to weigh in if you have any comments.
So thank you for this question as well. This question states that there is a subtype of MDS-U, which is MDS unclassifiable. This is a really odd kind of subtype because it's where a patient is so close to having myelodysplastic syndrome, but doesn't quite fit in the other categories that were previously described by the World Health Organization in 2016. And so it's this catch-all bucket where some hematologists may use to say, okay, I don't know where this patient might quite fit. What I would recommend first is before being confirmed with MDS-U, I would be sure that your bone marrow has been reviewed by another oncologist, hematologist, and a dedicated hematopathologist, just to be sure that this is really MDS unclassifiable, because it may look very close to something else. And so that being said, if it's truly that, there are some things being seen here that there's a deletion 7, deletion 20Q mutation, but then there is this TP53 mutation. TP53 mutation is generally considered one of the higher risk mutations, unfortunately. And so how it's being used right now is still up in the air. Like I mentioned earlier, there is a study that's looking at specifically this TP53 mutation and how to target that specifically. If you are doing quite well with low blood counts, with normal blood counts, and doing well from quality of life, watching and waiting is very reasonable. But, if there's a question about when to proceed to stem cell transplant, because of this TP53 mutations and these other mutations that are listed here, those are the ones that I would actually, talk to your hematologist about, is saying that, having a TP53 mutation does up the ante a little bit, because the scoring systems don't include that TP53 mutation. So are there other ideas or opportunities to consider other than watch and wait? But if you're over the age of stem cell transplant specifically, then watch and wait is very valid, and I think that's very reasonable to do.
Thanks, Dr. King. Diane wants to know, she's heard there is a new drug very close to being accepted by the FDA. And it's supposed to be very promising. She wants to know, do you know what it is? She has very low risk MDS with ring sideroblasts.
Thank you, Diane. There are always a lot of drugs that are being submitted and being proposed to the FDA. I unfortunately do not know what specific one that you're talking about because there are quite a bit. All those trials that I talked about have all been submitted to the FDA, but then been revoked afterwards when they don't meet its endpoints. Specifically, there is a oral azacitidine combined with that same agent with oral decitabine that is being looked at in clinical trials right now. And so there may be something that's similar that is going to be oral from a azacitidine standpoint, other than the oral azacitidine right now that's approved for acute myeloid leukemia. So I really don't know what specific one you're referring to because there are so many that are out there. I am not aware of one right this second that is just for ring sideroblast that is being in the FDA queue. For very low risk ring sideroblast, if you're doing extremely well, wait and watch is a good option, but luspatercept does have its specific FDA indication for MDS with ring sideroblasts.
Thank you. The next question comes from a 75-year-old patient diagnosed in 2019 with MDS RS MLD, multilineage dysplasia, with an IPSS score of 2.16 and has the SF-SF2, P95, R10del, and trisomy 19 mutations, diagnosed with low risk. As of now, all red and white blood cell counts are stable. Platelets are at 38, and they are being just observed with routine blood tests. Is it time for them to be more aggressive?
So this is really hard question, and I appreciate whoever submitted this, is at an age of 75 right now, it's the question of whether to consider stem cell transplant. So I may answer the next question first and then go back to this one. So the next question is, what is your age cutoff for stem cell transplant? Age cutoff for stem cell transplant at the University of Virginia for allogeneic stem cell transplant is age 74. So if you're 74 or below, we would consider you eligible for stem cell transplant, assuming that you don't have any other medical problems that would preclude you from stem cell transplant, like your heart, your lung, and your physical stamina all look okay. There are some centers that are looking at an increased age cutoff from 74 to about 76. So every center is slightly different, and it just really depends on how healthy you are, because there are some patients who are 30 years old who are not healthy enough for stem cell transplant, but there are some 76-year-olds who are healthy enough for stem cell transplant. So hopefully that answers that second question. But then going back to this original one that was listed here, was that at age 75, if you are eligible for stem cell transplant, and if you would like to go to stem cell transplant and consider what to do when you're saying, is it time to be more aggressive? I think these are things that I would definitely talk about with your hematologist and especially a stem cell transplant doctor. Because if you're going to be close to a time of transplant, we got to do this now soon before you reach over the age of stem cell transplant. And that would be the aggressive type of therapy to do. If you do not want to consider stem cell transplant and that is not in your idea, then it really is focused, instead of curative intent, is really trying to focus on what can improve your quality of life. If your platelets are 38 now and they are continuous to decrease, yes, platelets are dropping below 30. This is when I do think considering some sort of medication to improve your platelets could be helpful. And that'd be some of the potentially some of the platelet growth factors that we mentioned earlier, assuming that the bone marrow is still without those increased bad leukemia cells. So if your blood counts have dropped and there is a difference, what I recommend first is to get a repeat bone marrow biopsy done to ensure that this is still in the same category of myelodysplastic syndrome, ring sideroblast, MLD. If it is, then having an honest conversation with your hematologist, stem cell transplant doctor to see if moving forward with transplant makes sense. If not, then maybe focusing on just the platelets itself would be helpful.
Thank you, Dr. King. The next question is, does low-risk MDS always progress to high-risk MDS?
Thank you for that question. In regards to low-risk MDS progressing to high risk, on average, yes, it does, because theoretically, if natural course of disease is without any treatment, without modifying the bone marrow, if you get enough of those mutations, it could progress to, it likely is going to progress to higher risk myelodysplastic syndrome. Now, how long it takes to get there is slightly different for everyone. The best data that we have is through the IPSS-R scoring system. However, you may just need to think about that in regards to the IPSS-R scoring system. It doesn't include some of the newer mutation data that may actually increase the time to progression or actually decrease the time to progression.
Thank you. The next question comes from Elaine, and she wants to thank you, Dr. Kang, first for this informative webinar. She wants to know, what is the effect of fibrosis caused by MDS on the effectiveness of luspatercept?
Fibrosis is always tricky when it occurs in the bone marrow. So just for everyone to know, fibrosis is when your bone marrow, that middle portion of the bone marrow, instead of becoming nice and soft and spongy, it actually becomes kind of hardened, and it's more, for lack of better words, a little brittle. So it makes the bone marrow ineffective to actually produce those normal type of cells. Unfortunately, right now, there are not any FDA-approved medications, including luspatercept, to decrease or reverse bone marrow fibrosis. There are certain myelofibrosis drugs that are being studied right now in clinical trials that seems like there is a hint of reducing or actually reversing bone marrow fibrosis, but not luspatercept at this time.
Thank you. The next question comes from Robert, 65 years old and being treated for 2 years with for myelodysplastic syndromes, myeloproliferative neoplasm unclassified with excuse my pronunciation, Revlimid, 25 milligrams 2 times a day. They want you to discuss this class of drugs and any items of interest associated with this drug.
Absolutely. So thank you for this question. So MDS/MPN overlap disorder is what is being discussed here. And so when you have an overlap disorder, you actually treat patients based on what they most likely have, meaning if a patient more likely has MDS features, you treat actually with the azacitidine or decitabine medications. However, if a patient has more proliferative features, treating something with ruxolitinib or Jakafi is actually very warranted and can be used. Jakafi or ruxolitinib is a JAK1/2 inhibitor. So what it does is it doesn't really matter about the JAK2 mutation, but it actually works in that pathway to try to decrease the proliferation or the increase in blood counts. Things of interest is that in the United States, Ferritin is a JAK1 specific inhibitor, was newly approved about, I would say, 3-4 years ago. And that is something that is used commonly if patients do not respond to ruxolitinib. Just recently, actually in the last month, or actually this month, we have a new FDA indication for myelofibrosis is pacritinib, and it actually can be used in patients with lower platelets. And so this is really exciting because classically ruxolitinib and fedratinib often causes low platelets and cannot be used in patients with low platelets. So pacritinib may allow us to be able to improve these treating in these settings. Note that ruxolitinib fedratinib and pacritinib are not FDA approved for myelodysplastic syndromes entirely, but we can borrow some of the data to see if we can get approval from insurances.
Thank you, Dr. King. The next question is from Philomena. She's read on the MDS Foundation message board that some patients have been on Vidasa for over 5 years, some up to 10 years. Are there any bad side effects for long-term use? What is your insight on Vidasa and venetoclax combination therapy for early treatment as well?
So great question. Vidasa or azacitidine, based on that trial that we just talked about, is that we know that when it works, on average, it works for about 24 months or so. And from that perspective, most patients in clinical practice are less than the 24 months, as I said, closer to the, I would say, 18 to 20 months. It is amazing that a patient's able to get to 5 to 10 years. I actually do have a few patients who actually have been on Vidasa for that 5+ year range, and that's fantastic. Right now, there are not any known bad adverse events for long-term use. All the side effects that have been seen, patients would have received much earlier on, specifically like the low blood counts, the fatigue. Some people do have some taste differences after having azacitidine being used. My insight on azacitidine plus venetoclax for early treatment right now is that it should not be used in the setting for myelodysplastic syndrome outside a clinical trial. I think that there are some hematologists who are trying to get venetoclax being used. Unfortunately, using these things outside, we cannot interpret the data. We don't know how to interpret that data. So from my perspective, I would actually stay off of venetoclax in MDS unless we're looking at a clinical trial. And like I said, there are several clinical trials being studied right now.
Our next question comes from Robert. I have had MDS for 6 years. I was on Aranesp for 3 years, then progressed to blood transfusions for a year, then put on luspatercept, which lasted for a year, back to transfusions. Now my doctor has added Procrit to the luspatercept. Do you have any experience doing this? My hemoglobin is still between 7 and 8.5.
Thank you for this question. I think I have not added myself a erythropoietin growth factor, whether it's Procrit or Aranesp, to luspatercept. Theoretically, they are kind of different pathways. And so to me, I just don't think that would be, theoretically that could work. But if someone has not done well on a growth factor plus luspatercept, there's no data right now to show that would be of any improvement. What we did talk about earlier is that if lenalidomide or Revlimid was added to the Aranesp, there could be some improvement in red blood cell transfusions and hemoglobin. In regards to clinical trials, and I forgot to mention this, so I apologize, is that there are clinical trials being done right now when patients don't do well with luspatercept or a growth factor. And we actually have one at University of Virginia right now, is in these lower risk settings. If someone doesn't respond to these, what can we do? And it's adding other type of agents.
Okay, thank you. Our next question is, can you have treatments further than 4 weeks apart on Vidasa?
Yes, so that is the short answer. But the long answer is, before moving forward from spreading things from every 4 weeks to, 5 or 6, be sure that you talk to your hematologist. Usually what I would want is a bone marrow biopsy to be done first to ensure that there is a reason to spread the interval out. For example, if someone has chemotherapy, meaning Vidasa-induced low blood counts, then spreading the intervals out makes sense. However, if the bone marrow shows that there is increased leukemia cells or some other advanced stages of things that are causing the low blood counts, spreading out the Vidasa every 4 weeks apart would not make sense at that time.
Okay, our next question is from Diane. What is the average timeline for the watch and see stage for very low risk? She's 74 years old.
Great question. Unfortunately, we don't have the best answer at this time with it, because everyone's quite different, just like what you heard with the Vidasa. There's some people who can be on it for over 5 years and all. I will tell you that what we know right now is that from 2016 in the very low risk setting, on average, patients can have 10 even plus years before progressing to acute myeloid leukemia and its complications. It doesn't mean that you are watch and wait for 10 years because there may be some low blood counts or other problems prior to that time. So that's the best that we have. I would say in personal experience, I've had patients who've only been able to be watched for several months to some patients who've been watched for 7 or so years right now and still having very good quality life with good blood counts.
Okay, thank you. Our next question is from Donna. My mutations are SRFS2, ASXL1, TAT2, and RUNX1. Are these serious mutations? I am MDS MLD intermediate risk with low WBC ANC platelets. I had 4 cycles of Dacogen in the past, stopped because of COVID, and numbers were not coming up. Platelets gradually returned to normal and now are going down monthly. I have CMC every 2 weeks. Does it make sense to start Dacogen again when platelets get in the 30s? I am 76. Do you recommend a stem cell transplant at 76?
So let me tackle the first, the last question here first is, do you recommend stem cell transplant at age 76? So that's a very personal question, right? It depends on if you would like to proceed through all that. For a 76-year-old person, I would want that person to be very healthy, meaning that there should be very minimal medical problems, not like uncontrolled diabetes, hypertension, high blood pressure. Quality of life and the ability to do physical activity has to be very, very strong. So these are the type of patients at 76, they're, running marathons, they're actually, still working, or they're so active in some sort of physical activity. And so that would be the only setting that I would really consider transplant in someone who's 76. Now, before talking about restarting Dacogen and whatnot, is that, having COVID really has made things hard for all of us to interpret at this time, because COVID, the infection itself, and I even noticed the vaccines itself, seems to have affected blood counts, and it's very difficult to really interpret kind of what happens immediately afterwards. I've had patients who've had the infection whose blood counts are still low, even several months or even half a year to 9 months after the infections. So I don't know if the low blood counts, the low platelets that you're referring to right now is really due to the low, due to myelodysplastic syndromes, or really due to COVID itself. In my mind, when I'm confused and I don't know what to do, I actually do consider ordering another bone marrow biopsy to see if, comparing it with the other ones, are there new mutations, are there different mutations, and if blood counts are still low due to the myelodysplastic syndromes. Your first question here is, are these serious mutations? It depends on kind of what scoring system that you look at, because right now none of our scoring systems include all of them. ASXL1 is a scoring system, is a bad mutation that we always see in acute myeloid leukemia. Specifically in MDS, it's less of a problem, but it's not the best mutation to have. I would say that the TET2, the RUNX1, the SRSF2 are ones that are often carrying a little bit poorer prognosis. Not poor compared to TP53, but these are ones that are not as good. The best mutation, let me let me just go back to this. This next question that you have here is, if you have a specific mutation, so do you always have that mutation? So not always. So the goal of actually chemotherapy is to be able to, meaning Vidasa and the Cytobeam, is to be able to actually remove some of these mutations via treatment. And so I've had patients where they had 10 or 15 different mutations, and specifically after chemotherapy, is that we've lost some of the mutations. And then when we are talking about relapses, is that we may see some of these mutations come back a little bit faster. The only mutation that is good at this time is a SF3B1 mutation, and that's the mutation that's associated with ring sideroblasts. That's the only one that we know as of right now is associated with good risk for us.
Thank you, Dr. Kang. Next question comes from Cheryl. Can nutrition play a role in the quality of life or survival rate for MDS?
So there is no FDA clinical trial that has proven that nutrition is better for this quality of life or survival of MDS. However, out of just personal experience, is that if my patients could be healthier, right? If they can be eat better and to actually, and I'm going to pair this up not only with just nutrition, but with exercise. If you're able to have a well-balanced diet, to be able to be out there and be active, yes, your quality of life can be better. We just don't know how it affects overall survival. Of course, if a patient is not eating well and they're getting chemotherapy, potentially quality of life is not going to be as good. So from my perspective, it's important from that perspective. There is not a scientific data to show that is there a specific diet that's better than another, meaning we don't know if one certain types of food is better. I usually say well-balanced diet, and make sure that if you're taking any extra supplements or minerals or nutrients, is that you talk it over with your hematologist to make sure that there is no drug-drug interaction with the treatment that you're on, or that there's no problems with a clinical trial that you may be participating in.
Okay, thank you. Our next question comes from Barry. His father is high risk. He's 76 years old. He was treated with Vidasa and restored his blood levels to normal. After 24 months, the blood levels began to drop. That was in November. Now it's March, and his quality of life is pretty much where he was before he started the Vidasa. His question is, any suggestions of things to try next, and what should they be looking at as far as time frame, and what to experience so they can be better prepared?
So that's a big, like a fully loaded question, but let's try to go through each one of the steps right here. So your father was treated with azacitidine or Vidasa, and I'm glad to hear that the blood levels were restored, and now it's unfortunately beginning to drop. So before any clinical trials, if your father decided to do nothing, this is where things become very difficult, is that myelodysplastic syndrome has now progressed and has relapsed after the azacitidine Vidasa. Without any treatment, on average, survival's about 5 to 6 months from the time it stops working. Now, this is just very average. It was with older data, but this is just kind of what we say. We're in a very tough zone at this time. So what I would suggest, so that hopefully answers the first one. The question is like, what time frame is that? We'll be looking at about a half a year without without other treatments. What I always tell patients, though, is that when patients progress from myelodysplastic syndromes to acute myeloid leukemia, there's actually more drugs that are approved in myelodysplastic. So there's actually more drugs that are approved in acute myeloid leukemia at this time, specifically Cytobeam, venetoclax. If there's any FLT3 or IDH1 or 2 mutations, those are specific drugs that can also be used during that time. So from my perspective, what we used to quote of the 5 to 6 months was because in acute myeloid leukemia, we had nothing to offer. Now there are things to offer, so that may not be as applicable. The other thing that we would recommend right now is to consider a clinical trial. If your father wants to participate in more and more type of trials and actually receive treatment. The trials that I mentioned earlier, and those are just two that we have here at UVA, there are other trials at other academic centers across the United States, is looking at combining venetoclax with the azacitidine and lepremab for those who progress in this setting. We also have the BioSite trial that actually is specifically geared for patients arising from this setting here. So I think those are things to really consider, is that we've really shown that this out of personal experience. I've had a patient who, Vidasa worked very well. Unfortunately, when he progressed, quality of life decreased very dramatically, but then that BioSite clinical trial really just kind of turned around and he developed a remission, and he's continuing on moving forward with great quality of life. Of course, that's one patient, but there are options that are available if your father would want to pursue them.
Okay, and thank you very much, Dr. Kang. And our last question is, should people with MDS get the COVID vaccine, and should they get the 4th shot?
So I do recommend it. Although myelodysplastic syndrome, you may have normal blood counts, it is a cancer, and I would consider patients with cancer more immunocompromised than others. And I'll answer this question, but just to say that there was a study that was published by the American Society for Hematology, and it showed that when patients had COVID in the setting of blood disorders, that patients with COVID actually do worse than those without a blood disorder. So we do recommend patients to get the COVID vaccinations and to get all relevant boosters. So that's even boosters 3. Right now, I have recommended my patients to get booster 4 as long as they're at least 4 months apart. I've had some patients who actually are getting the monoclonal antibody, the Evusheld, to actually help boost the response to the vaccinations and against COVID.
Okay, thank you very much. Thank you, Dr. Kang, for joining us today, and thank you for your wonderful presentation and for volunteering your time today. If you've missed the webinar, would like to view it again, it will be posted to the MDS website within 7 to 10 business days. An email will be sent out letting everyone know. If you had any questions that went unanswered, you can contact Audrey Hassan at ahassan@mds-foundation.org. Thank you, and have a great day and a great weekend. Thank you again, Dr. Kang.
Bye, thank you.